So now we're going to do the review on the pericarditis PowerPoint for Nursing 203 at our school. I'm not going to say the name because I don't want to say something bad and then have the school affiliated with it. So now we're doing pericarditis. So what is it? Pericarditis is basically an inflammation of the pericardial
sac.
Thank you. Normally there's about 10 cc's of fluid in the pericardial sac. Mainly its purpose is to prevent things like friction rub, while the heart is contracting, repolarizing, depolarizing, so to speak. You have two types of pericarditis. You can be acute or chronic. Acute obviously is a sudden onset, and chronic can be progressive, leading to other complications such as right-sided heart failure or things like that. So the stressors, as you know, I'm a mnemonic freak. I think of the pericardium as a bra. A bra holds the breast, so the pericardial sac holds the heart. So the stressors are, do the MI bra. And the stressors include drugs like, I forgot the name of the drug. Pronestal. Pronestal is one of them. Dilantin and penicillin can be stressors to pericarditis. You have others, which could be a secondary result from a neoplasm, from uremia, which would be presented with elevated levels of creatinine and BUN. You would have trauma and surgery. Those are other stressors that can precipitate pericarditis. Myocardial damage. You have something called Dressler syndrome. Dressler syndrome is basically a hypersensitive response to necrotic tissue, and your body responds. That could be a stressor of pericarditis. It can inflame the pericardial sac. Idiopathic. It could have a sudden onset. It could be either bacterial, fungal, or viral. It could be caused from radiation to the chest, or autoimmune disorders such as rheumatic fever in children, rheumatoid arthritis, and lupus erythematosus. So pathophysiology. What's the nature? Basically what's going on is that there's an inflammation. Obviously you have itis, and that's causing it to have a rough surface. That rough surface is going to give the patient pleuritic pain. That pleuritic pain is what distinguishes it from angina. It's not pain that's coming from this, the sitting pain. It's pleuritic pain, like breathing. As the patient is breathing, he's having pain. It's mainly on inspiration. So that pleuritic pain and friction rub is going to be caused secondary to the inflammation. And what's going on is that there's excessive fluid in there, and that excessive fluid is going to result in cardiac tamponade. When you're listening to someone's heart, that cardiac tamponade can be presenting like a distant or muffled heart sound. You're not going to hear it as well as somebody who didn't have excessive fluid in there. It's just a beat that's further away, pretty much. That's the way I can explain it in layman's. So what are the effects? The effects of it's going to constrict the heart. There's more fluid in that sac, so now the heart can't expand and contract as efficiently because there's something pushing on it. And now, as a result, you're going to have a decrease in cardiac output. So how is your body responding to this decrease in cardiac output? Obviously, your body's going to try to correct it. So it's going to become tachycardia. You're going to have tachycardia because your body now has to work harder to get all that blood flowing as it should. So you'll have tachycardia, and you'll even have maybe no pulses either in the periphery. And what happens is something called the classic V, which is a narrowing of blood pressure. A patient could present with a blood pressure of, say, 120 to 80. And that V means it's going to start at those two numbers and start going out further.
No, it's the opposite. It's narrowing.
Narrowing, I'm sorry, thank you. So 120 to 80, and then it'll come closer and closer, presenting itself in like that classic V shape. Okay? So the assessment. The patient is going to have sudden pain. So obviously pain is definitely a priority nursing diagnosis. They're going to feel the pain in the sternum like the angina, except this pain is more pleuritic, meaning that it's felt when the patient is inspiring air. And what helps that pain is to lean forward, pulling your heart away from the diaphragmatic pleura. That helps with the pain. Pain is increased with movement, swallowing, and coughing. Note that this pain does not respond to nitroglycerin like angina. So that's one way you could try to maybe, well, you'll just know. If somebody were to be given nitro, you know, in a false effort to think they have angina, then it's not going to work for them. Low-grade fever, you have symptoms of impaired cardiac output, and also symptoms of heart failure may occur with cardiac tamponade. You have something called pulsus paradoxus. Pulsus paradoxus means that the blood pressure will decrease when the person inspires air. You have pericardial friction rung, that's enough said. You're going to hear that, almost like that grating sound. And obviously it's going to be painful for the patient. Diagnostic tests. Diagnostic tests, you're going to see an increase in white blood cells, and that could be directly attributed to the possibility of a bacterial, fungal, or viral. So obviously, in order to determine whether it's viral or bacterial, you'll do like a CBC with diff to figure it out. You have an echo. You have positive cultures if there is an infection. You have an increased ESR, which basically is going to denote inflammation of some kind, and an EKG. So it's I-E-PI for the diagnostic test. And then the treatment. The treatment is a SNAP. You can thank Margie for that. She figured it out. Steroids. Steroids like Solumedrol you'll use to treat the patient. You'll have NSAIDs like aspirin, Motrin, and Indocin. You'll have antibiotics if it is a ineffective pericarditis or possible bacterial. Pericardiocentesis, when they'll literally go in there and drain the fluid out of the pericardial sac. And pericardial window, where they'll create a surgical opening to drain the fluids, the excessive fluids that are in that sac, to allow the sac to heal, and what's left to let it be reabsorbed by the heart itself. And then your nursing care. Nursing care, this is the steps that you're going to obviously take to care for somebody with pericarditis. We're going to try and decrease cardiac demand with bed rest. We're going to keep that patient in an upright position. It's just noted to be a little less painful when you can be sitting up, leaning forward. Remember, that's key. Oxygen supplementation. You definitely want to keep this patient well oxygenated. You want to monitor for signs and symptoms of cardiac tamponade. We want to try and avoid that at all costs. Analgesics, because again, pain is a priority diagnosis. And then a pain assessment. You want to do an accurate pain assessment to help the patient, to identify if it's, you want to differentiate it between angina. Remember, we said angina and pericarditis can be often mistaken for one another, so you want to be specific in that assessment of pain. You want to figure out what kind of pain the patient's feeling. Again, it's a pain that you're going to feel in the sternum, but it's not that elephant on your chest, so to speak, and it's more of a pain that comes from the pleuritic region where the patient is breathing in. They're going to feel that pain. That pain isn't specific to an angina type of pain. So, good pain assessments. And that's basically a snitch, guys. That's it. Thanks.